how could rating help?
Great. Thank you for inviting me and giving me the opportunity to say a few words. So I thought I'd spend 25 minutes talking and then the rest of the time on Q&A. So I'll try to do 3 things in my 25-minute slot. The first one is to map the concerns that arise in healthcare innovation and talk about where Nicole's Global Health Impact Index fits within that broader landscape. Then I'll discuss the role accreditation, certification, and rating programs or indices might play in addressing some of those key concerns. And finally, I'll conclude with some summary remarks about the promises as well as the pitfalls of developing and launching accreditation, certification, and rating systems. So the first thing is to landscape the ethics, human rights, and population health concerns within healthcare innovation. So the Global Health Impact Initiative falls towards the 5th bucket, but the first area of concern would be around the way that clinical trials are designed. So when you have an idea about a new medicine and vaccine, the first thing you need to do is to test the idea. And when you run that test in people, it's called a clinical trial. Sorry, it's easier to hold it. So here, the overarching concern around clinical trials is that they might be biased in a way that would maximize the appearance of benefits and safety of a new medicine and vaccine and minimize the appearance of harms. And you might do this because you'd like to gain regulatory approval more quickly or to sell more products. And there are many ways that people are worried that clinical trials can be biased, one of which would be to cherry pick your research subjects, the people on whom you test your drug, or to cherry pick your research setting. So not putting any weight behind whether this actually happens, just saying that these are the concerns that people have. So here's an anecdote. Imagine you're running an osteoporosis drug trial, and you decide to run your clinical trial in a small town in Brazil. And the starting calcium levels of that population happen to be very low. Now, you submit your product for regulatory approval in the United States, that's to the FDA. The FDA approves the product, but when it's released in its intended market, maybe here it's the US and Europe, it's clinically ineffective because our starting calcium levels are much higher. And so there are plenty of experts that argue that this type of bias falls outside the purview of most, if not every, gatekeeper. On the other side, you have experts that say that's not true, that if you limit the people on whom you test your drug, you run the risk of limiting your marketing approval, what the FDA will approve your drug for. The next type of concern is the way the clinical trial is actually conducted. So if you think about your 2012 drugs that were approved, there were roughly 39 of them. There wasn't a single drug that was approved that wasn't tested outside the United States, and increasingly in emerging economies. And so the most conservative number and also the leading number is that 40 to 60% of clinical trials are now done outside the US and increasingly in emerging economies. I think that number is much, much higher now. And so there are a lot of concerns that arise in that. There are good things like these populations now get to understand how medicines work for them, right? So we want to know how medicines work for different populations around the world, but there are also concerns. One of the concerns would be around the quality of informed consent. So what if that trial represents the only access point to care or to that medicine and vaccine for the trial participant? What impact does that have on the quality of their consent? Or the second question would be around the responsiveness of the clinical trial to the local population's needs. So are we testing drugs for male pattern baldness or allergy medicine on people who need access to clean water and tuberculosis medicines? The third type of concern regards the fate of the information learned from the clinical trial. And so here there's a lot of concern that the favorable results of clinical trials are easy to find, but the less favorable ones, so the ones that don't make the drug look particularly helpful, are not publicly available. So the concern is that there's missing information and misleading information. So first, a comment on the misleading concern. So there was an article published on a celecoxib trial. That's a medicine for arthritis. The trial was published in a very reputable journal, JAMA, but it was based on outcomes at 6 months. Now, the full trial was for how long? Any of you who knows this case knows it was 12 months, 1 year. So you'd have to say, why was the trial published at 6 months versus 12 months? Because the drug looked very good at 6 and not so good at 12, right? So that's an example of misleading information. Now, if you think about missing information, these are the drugs that the FDA approved in 2012. They were manufactured by large pharmaceutical or biotechnology companies, and they're for a bunch of different therapeutic areas. So you see, for the purposes of this talk, HIV and tuberculosis medicines. You see a bunch of cancers, glaucoma, arthritis medicines, and a meningitis vaccine for children. And here you see the transparency of pharmaceutical companies varies widely. For HIV medicine, only 21% of the clinical trials conducted, and there were 34 of them, only 21% are publicly available. But then on the other side, you start to see some best practices with some companies and some drugs 100% transparent. Now this is my own index, but it's relevant to Nicole's index because Nicole is using data. Some of her data is publicly available data, and I think it's very helpful for her and others to understand how complete the evidence base that she's working on. But moreover, all of the prescription guidelines that your physicians use to make your healthcare decisions are based on reviews of public data. So if your public information is partial or more likely biased, it runs the risk of compromising the integrity of your clinical guidelines. Now, and I'm going to show one more slide. This is a voluntary standard. Companies actually aren't legally required to disclose all clinical trial results, only some clinical trial results. And that's about 4.6 trials out of an average of 22 that are conducted. So it's a very narrow law, but you can still see, despite the narrowness, very low compliance with transparency standards. Another reason for caring, other than this being a population health problem, is that this is Ryan Wilson. In 2006, Ryan Wilson signed up for a clinical trial. It was for a molecule called TGN. And within 6 hours of enrolling in the clinical trial, he suffered organ failure. His fingers and toes began to rot and actually fall off. And he was hospitalized for 146 days. And it turns out that the TGN molecule had been tested before, 10 years before, but it had never been disclosed. And so poor Ryan and his 5 fellow volunteers could have been spared a lot of suffering if the results of that clinical trial had been made publicly available. And finally, going back to our 5 buckets of concerns, there are concerns about the way that drugs are marketed. Here, critics ask, why do a lot of companies spend more money, sometimes double, marketing drugs than researching and developing new ones? Although I will say that it's on par with other tech industries. There are also concerns about off-label drug promotion. Pfizer, for example, in 2009, settled a case for $2.3 billion related to marketing its products for indications that have not been approved by the FDA. And GSK similarly paid $3 billion fine. And there are also concerns around a lot of the continuing medical education programs for physicians are funded by the pharmaceutical industry, raising questions about whether that's education or marketing or something in between. And then there's some more outright cases where in China, GSK and other companies were caught directly bribing physicians to prescribe their medicines. And finally, and this is the bucket that's most appropriate for today's talk, is there are concerns about the accessibility of medicines and vaccines. And here the obvious question is around pricing, right? And you hear a lot of questions, why do tiny white pills cost thousands of dollars? Which is a problem, of course, in a developing country, but as we all know that in many emerging economies, medicines are the second largest household expenditure, followed directly right after food. But even if medicines were free or discounted, and there are a lot of practices that are emerging around discounting drugs, inter and intra-country tiered pricing, it's hard for developing countries to access them. They lack infrastructure and the capacity to distribute drugs. So we've talked about the lack of clinics, right? So sometimes a clinic is 3 moons away. And so my mom does medical missions, and she'll ask a patient or a townsperson, how long did you wait to see me? And she'll say, well, I walked 5 moons and then I waited 2, right? So that's 7 days to see one physician. But also there's a lack of electricity sometimes, right? So electricity grids. What do you need to store and transport vaccines? Cold chains, right, refrigerators. So that's an infrastructure challenge. Now you can think about building infrastructure, right? Cold chains, electricity grids, more clinics, but you can also innovate around some of the infrastructure challenges by using adaptive technologies. So if you don't have access to electricity, maybe you could create heat-stable medicines. Or if you can't get back to the clinic 3 times in a year, maybe you could develop fixed dose technologies, right? So 1 dose versus 3. Or have medicines that have longer shelf lives. So those are all things that fall under the category of access to medicines. Now, if I were you, and I were sitting in your seat, I would say something like, Jen, that's really interesting, but I'm skeptical because a lot of the issues and concerns that you're raising could actually be old issues based on old data. They could be the product of rogue employees in an otherwise good pharmaceutical company, so that bribery was, one employee's problem, but not the company as a whole, or it was an outlier company, but not the industry. The industry is genuinely doing pretty well. And I suspect that herein lies the value proposition of accreditation, certification, and rating systems. So accreditation, certification, rating systems, and indices, like the one Nicole created, can do at least 7 things. It should be top 10, but I have 7. The first one is they can set standards and define what good practices can and should look like. And then you can measure the degree to which those standards are implemented within institutions or products. So you can look at institutions, products, or services, and that's an important decision to make when you're creating these programs. And that leads to a more data and evidence-driven conversation. You can also identify best practices, right? So when you go back to the index I was showing you, you can see that there are at least 3 or 4 companies that are 100% transparent. And what that does is it opens up the door to ask, how did you do it, right? So some of those companies created software that automates some of their reporting practices. And so that's an important aspect of Nicole's work, is that she can create a platform for learning and knowledge exchange. And this is certainly what I've seen happen, where the low scorer reaches over the table and asks the high scorer, how did you do it? How can I repeat that? And so it's not just an incentive design mechanism, how the literature generally credits these things as institutions wanting to score well, but it's a genuine opportunity to learn how to improve practices, and that can lead to improvement, change in behavior. And perhaps a good example of that was the Joint Commission. That was one of the oldest accreditation systems, at least in the social science literature. The deep historians go back to commodities exchanges. But if you're a social scientist, you say that the Joint Commission was the first accreditation system. It started in healthcare, so it makes sense. 100 years ago, it was a bunch of surgeons got together in a room and said, we would like to operate in safe working conditions so that we can provide better care. So they drafted up a set of standards that they thought represented safe working conditions. So it was a peer review system. And then they went about and evaluated and measured I think it was 141 hospitals, but don't quote me on that number. It's been a while. And the results were disastrous. Most of the hospitals failed the standards. It was so embarrassing to the healthcare sector that they burned the results of their evaluation in the chimney of the Waldorf Astoria in New York City. So hopefully Nicole does not have to burn her results. But within 5 years, most of the hospitals were meeting or exceeding the standards set by that small group of physicians. And it's been said that the Joint Commission was to hospital betterment that as the Sermon on the Mount is to great religion. So basically it had a lot of impact. Now, why would the pharmaceutical industry, the area that Nicole is working in, be particularly well positioned for the type of for an accreditation, certification, rating, or index? Part of it has to do with the fact that it's losing its social license to operate. The trust in the industry has plummeted, and it can be summarized in 4 numbers: 12, 70, 1, and 16. 12% of Americans trust pharmaceutical companies are generally honest and ethical. 70% think that they put profits before people. And all of those 5 buckets are manifestations of how that might occur. But one is what the industry used to be. It was the #1 most respected and trusted industry up until about 17 years ago. And this year it's below Wall Street and barely above tobacco companies. Now, the industry knows that it should do something. When trust dips too low, there are costs for the industry. For example, you are at risk for reactive regulations rather than rational ones. And you can see this in India. When there was a scandal there, there was a clinical trial conducted. Some people died. It wasn't clear the source of the death. And India barred all clinical trials within its borders for 3 months. All clinical trials. You can see the EMA, that's the FDA of Europe, has been raising its standards around clinical trial transparencies. China is trying to do some similar things around pricing. So high levels of distrust make the industry vulnerable to reactive regulations. Second, you can have a hesitancy by payers to reimburse for medicines when the value proposition is in question. And again, you want rational reimbursements. It can be harder to recruit research subjects for clinical trials. And there's some evidence that patients hesitate to take drugs, particularly elderly populations and minority populations, when the trust is too low. So basically, when trust dips too low, it erodes the degrees of freedom a company has to operate. And this can stifle innovation, which ultimately hinders access to cures and therapies, which is problematic for advancing global health goals. Okay, there's a slide somehow missing. But the question becomes, what can you do to start addressing some of the concerns that I mentioned? And the pharmaceutical industry is not the first industry to suffer from quality as well as, you can think of them as reputational challenges, but really they're trustworthiness issues, right? Because trustworthiness and trust are not the same thing. You can trust a used car salesman that sells you a lemon, but trustworthiness is something more deeper inherent. And all of these industries that have suffered from quality and reputational challenges have turned to accreditation, certification, ratings, or indices as a way of improving things, both of assessing the depth of the problem and demonstrating when there are quality services, processes, or products. And they increase transparency, accountability, stakeholder confidence where appropriate, and awareness of best practices. So you can think of the Kimberly certification, which was started to prevent diamonds from being converted from symbols of love to symbols of bloodshed and conflict. You can think of the Flipper seal of approval, which was started in large reaction to civil society activists threatening to boycott canned tuna that was caught with nets that were unsafe for dolphins. You can think of the Rainforest Alliance or the Forest Stewardship Council, which was created to signal when there are environmentally friendly timber products. and slow the destruction of the environment. You can think of AHARP, which was started to signal the quality of institutional review boards. Those are ethics committees that approve clinical trials. Car safety rating labels, the Joint Commission I mentioned, or credit rating agencies for investment opportunities. So what are some lessons that you might learn from these groups? So this is based on starting my own index, but also having evaluated 75 quality improvement initiatives. These are some things I leave for the GHI group. One, you have to set your priorities, right? Which issues are you going to tackle first and why? And sometimes it's easiest to address things that are easy to measure, right? So you need to set your priorities and have a clear justification of why you're starting there and what you're going to do next. Secondly, when you set your standards, there's a decision to be made. Do you set a floor or a higher bar? And if you can, I would suggest doing both. So that's what I did. I set a higher voluntary standard, and the floor I linked to a policy, right, to a regulatory governance structure. This allows you to inform policy. So one of the things that when you measure compliance with baseline laws, you find out that it turns out many laws aren't met, they're not enforced. And so that allows you to look at why, right? What are the barriers to compliance with the law, or what are the problems with the law? And so you can be a real active informant for the policy debates. A question that needs to be asked is what to do about low scorers, right? Do you name and fame and identify best practices, or do you also shame bad practices? And that's something that needs to be decided at the outset. You also need a salient system. R. Kung Feng writes a lot about the perils of transparency, and that you can create the best data, but if nobody uses it, was that a good idea? And so for something to be salient, it needs to signal to the right people at the right times, at the right places, in the right ways. And I think a good example of this is the car safety rating labels. They're embedded right in the choice architecture of the decision maker. So when you go to buy a car, and I just bought one, on the window in the showroom is the safety label. So I guess the equivalent question for the GHI index is, who's your target audience? Who needs to see that index, and where and when do they need to see it? So what is your car window? Governance structures are incredibly important. I understand that right now it's an advisory board of academics, but as you think forward, the index evolves into a type of governance structure, and so that needs some formalization. And so there's at least 3 ways that you can set these things up. These are names for convenience, just how I think of these. So there's a technocratic, conflict-free model where all of the decision makers who set the priorities, set the standards, set the measurement instruments, and do the measuring have no ties to the entities that you're evaluating. This type of model is often created to avoid risks of institutional corruption. If you're interested in knowing what institutional corruption is, read the work of Larry Lessig or Dennis Thompson. And this can be cultural capture or financial capture. And if you think about credit rating agencies, they now suffer from financial capture in that they rely on fees paid from by the entities that they evaluate. But this was not always the case. Actually, prior to 1970, the fees were paid by those who wanted the information, so the investors. So that was a more recent model change. On the other side, from the technocratic conflict-free model, you have a multi-stakeholder and more deliberative model where all impacted stakeholders sit at the table. And here you can think about the Rainforest Alliance or the Forest Stewardship Council certification as being under that model. You can also think of this as being the National Transportation Safety Board as being multi-stakeholder. And there's a group at Duke led by Ed Ballison who compared the success of the National Transportation Safety Board versus the Chemical Safety and Hazards Investigation Board, and why was one more successful than the other. And one of the metrics that they came up with was this multi-stakeholder model where the industry gets a seat at the table, and they summarized it with this: participation begets collaboration and helps with legitimacy. Or you can go in a different model where it's a peer review. I don't think you're going to do this, sort of self-regulatory model, but this is AHARP's model. NASD was the precursor to FINRA. It's in Wall Street stuff. So AHARP accredits and evaluates institutional review boards, so ethics committees, and that's really where fellow IRB members evaluate fellow IRBs. So it's a peer review system. Perfectly on time for once. Okay, so I wanted to conclude with some inspirational quotes. I think that building an index is an incredible endeavor, which has the potential to impact an industry as well as people's lives around the globe. But it also has an immense opportunity to participate, to contribute to the scholarly literature on what it means to be a participant scholar, which I'd say is arguably still new, or at least a minority within the academy. And I'm going to conclude by echoing John Braithwaite in Australia and say that I think it's possible to be a passionate person about the normative, but dispassionate about the empirical, so warm on values and cold on the analysis. And my hypothesis, as well as John's, is that you can have better explanatory theory, that is, propositions about the way the world is, and better normative theory, that is, the way the world should be, when you integrate both the explanatory and the normative, which is, I think, exactly what Nicole is doing, and which is why I'm so excited to be part of this. Thanks.
So I have a question while everyone else thinks about one. Okay. So you mentioned that the GHI should think about a couple of different questions. And one of them was about what you would do with low-ranking companies. And so I'm interested, because you talked about the social license that companies have, and how the social they have less license than they did before, right? So I'm wondering if shaming would be really effective for how we treat lower-ranking companies. It doesn't seem like the ethical thing to do, but I'm wondering if, merely in terms of being effective, if it's better than just faming the higher-ranking ones that you mentioned.
Yeah, and so I think the empirical evidence on which strategy works best is all over the map. So if you think about restorative justice approaches, they would say maybe stay away from the shaming and instead emphasize the best practices and an opportunity to learn from them. On the other hand, there's plenty of evidence on the other side to show that these indices that both name and fame as well as shame are creating great incentives for change. So I'm not sure which is the best, but perhaps that's something you could actually experiment with as you launch programs.
Thank you.
Mm-hmm. Yeah.
Hi, I'm Mara. So as you were speaking earlier about drug companies in terms of getting their drugs approved, I work in the healthcare industry. I've worked for a pharmacy before. Seems like they're trying to push out their product the quickest just to kind of make money, and not always, but is there any incentive for them to actually make it safe as opposed to just pushing it out? Because I don't know if, I don't know. That was what I was thinking about while you were speaking earlier on in your presentation.
So I'm going to sidestep your question for a second, because it's hard to know the motivations of the individual decision makers within pharmaceutical companies. But the FDA regulates safety and efficacy. What the FDA doesn't regulate is superiority, right? And so in some ways, thinking about whether the product is safe and effective is the lowest, the lowest possible thing you can ask of an institution, right? What we also need to know is, how does your product compare to the similar products on the market? And that requires pragmatic clinical trials. So it's after your intervention is approved, how do you compare the approved interventions to each other? And there are no incentives, right? And maybe if you're a payer, you'll fund a pragmatic clinical trial to know which is the most cost-effective intervention. But if you're a pharmaceutical company, unless you're really darn sure that yours is the leading comparator, you probably aren't going to fund a pragmatic clinical trial.
My name's Lindsay. So a lot of the examples that you gave around the rainforest and tuna and car industries, you have a lot of options within those as a consumer, but with pharmaceuticals, you're kind of limited in what you can access for certain drugs. So what advice would you give consumers trying to make an impact to make things better in the pharmaceutical industry while they're still constrained by what they can access for drugs?
So I'm going to talk about my index for a second. So you have to decide who your stakeholder is for your index, and it doesn't have to be consumers, although it can be consumers. But consumers can be more broadly thought of than just patients, right? There are people who sign up for clinical trials, so research participants. There are the payers, right? So governments and insurance companies. There are the governments that allow the clinical trials to take place within their borders, or the hospitals and physicians that partner with the pharmaceutical companies to run clinical trials. And the list goes on. And so the first consumer of these types of programs may not be the patient. So for my index, for example, I think it's the patient advocacy groups, right? They don't want to recruit research subjects for trials that are not leading to generalizable knowledge. That's not okay, right? Clinical research is defined as that which can contribute to generalizable knowledge. When you hide the information, that's not happening. So they're one of the target audiences. Also, the clinical guideline writers who use the clinical trial information. It's in their interest to have complete and accurate information. So that's a second consumer. Patients, you'd have to have an incredibly accurate and continuously updated database for it to be a consumer-driven index. And so mine is a static snapshot at 1 year and 30 days post-approval of a medicine. And so for a consumer to use it as a comparative decision-making tool, so should I take this drug versus that drug, you'd need it to be continuously updated, and that takes more funding. So I couldn't be a consumer-driven, nor do I feel comfortable being a consumer-driven seal or index at this point. But investors is another one, and underwriters, so those that insure the pharmaceutical companies are very interested in this type of information. So I just would say consumers, yes, but which consumer you're talking about changes depending on the index, as well as the lifespan, the time that you're in the lifespan of the index.
It's all right, no, it's fine. I'm Laura. Going back to the Joint Commission, the Joint Commission has a lot of influence with hospitals in terms of like Medicaid funding and Medicare funding. Do you think some governmental aspects to creating an index or insurance company related control could affect the existence of an index? Because it seems like the government could have more to say, and that the actual pharmaceutical companies could benefit greatly from an index, but they would all have to agree, and they all have to be convinced, and they're going to spend more money on lobbyists than they are to actually change the system.
So there's two sets of indices. The first is the ethics index, which is voluntary, right? Voluntary standards that all clinical trial results should be disclosed. But the second is the legal compliance index. So there's a law that was passed by the FDA in voluntary standards in 2007 called FDAA, which said that basically all interventional non-phase 1 clinical trials, which is roughly 17 to 24% of your clinical trials conducted to gain regulatory approval of a drug, must be publicly disclosed. And so what you see from these numbers is, I hate to use the word, a failure by the FDA to monitor and enforce the law that it set. And so in this sense, you can see a potential for the index to help the FDA, which is understaffed and sometimes under-budgeted, fulfill its mission, right, and fulfill the laws that it passed. So there would be nothing from stopping the FDA from issuing letters and perhaps doing more than that for some of these non-compliant drugs. So it could support legal action as well.
Do you think insurance company reimbursements would affect compliance with laws like this?
So I think from the insurance companies, the formulary decision makers, right? So which drugs are covered, they also rely on public information, right? And so here they can see that the information that they used to make their formulary decisions was partial, and they might want to recalculate and reach out to the companies and have all the information. And there's one study that shows that the information that is disclosed is twice as likely to be the favorable information. So I wouldn't be surprised if our cost effectiveness studies look differently if you were to incorporate all of the information in them.
Okay, we have time for one more brief question.
Okay, so I was curious about one thing you said. So you seem to suggest at one point that the reason you want to, so in order to tackle access to medicine, the reason we want to tackle the pharma companies is because they've lost their social capital. That was that slide where you gave the numbers, how 16 or 17 years ago they were still number one, and now they've completely lost public faith. Now that seems to be a different kind of argument than saying the reason we want to rate pharma companies or try to encourage pharma companies to change something about their behavior and make medicines more accessible is because they are primarily they're the driving force that creates this problem. But in the story you told about your mother, for instance, the problem and what you portrayed nicely was that pharma and medicines themselves are only part of the problem. There are larger infrastructural problems and problems of poverty and all kinds of other problems. So how do these two things go together? So would you say that the reason we approach pharma companies, or the reason they are in our focus, is because they can be approached because their social capital is low, or because they should be approached because they're such a big driving force? Or how would you?
So there are a lot of different groups doing a lot of different things with the same end goals, right? Which is get people access to healthcare everywhere around the world, and broadly speaking, access to all different types of interventions, whether it's access to a physician, access to a nurse, access to a medicine, access to a vaccine, clean water, right? So going back to my mom, she realized that she's treating illnesses that are even deeper problems, right? The water is unclean, so now she's building wells and giving out water filters. So the picture is so big, right? And the problems are so deep and so wide that we all need to work together, which is one of the reasons, again, that I think that this type of event is very important, so that all of us who have very small pieces of the puzzle can continue to collaborate going forward in a way that's not duplicative, but mutually supportive and reinforcing, and maximizes the small amount of resources that we have. And so you're spot on, right? There's all different reasons of why people engage in these things, and there's all different ways. And my answer is we need most of the reasonable and legitimate ones, right? And we need to collaborate together. And I wasn't saying that the reason I got involved with this was because of the social license aspect for pharmaceutical companies. But that is one of the reasons that they might come to the table, right? And that's it.
Thank you. And okay, so next we'll have